It is Friday, and so today is our day at Ivy League Tutoring to do our live video. So we did a live video with you guys last week, and we went over some endocrine review. We did Cushing's versus Addison's, and we were really excited about how many people viewed our video. We had almost 25,000 people viewing that video, and we had a lot of students that contacted us telling us how helpful it was. So this week we are back, and every Friday we'll be doing a live video for you. So we have some big announcements today. We have some big things to talk to you about, and then we're gonna hit our cardiac review today. So a couple things. We would first like to do a big shout out to our friends at simplenursing.com. If you guys haven't checked them out, be sure to do so. They have a lot of videos and a lot of resources that are amazing for you guys during nursing school, so be sure to check them out. Second thing is that we have a new texting service, and so we will send you different links to promos and giveaways from Ivy League Tutoring. We will also send you different things for discounts that you can use for sessions and for some other things that we have here that we'll talk about in a few minutes. So if you guys are interested in subscribing to our texting service, you're going to text 85100. You'll text nursing, the word nursing, NURSING to 85100, and you can subscribe to our texting service. We only send out a couple texts. It's not gonna bombard you too much, but we do have a lot of really great resources for you and lots of cool giveaways and things like that, so you're gonna wanna check that out. We also sent out a link this morning, and we're gonna put a link in the comments here later after this video is finished for our new YouTube channel. You can subscribe to our YouTube channel, and we're gonna have all different kinds of videos for you guys that we're gonna start posting every Friday, and then every once in a while we'll pop in and do a big surprise video for you on something that we thought that would be really interesting for you guys to learn this week. Nursing school is super hard, and so we are absolutely here to help you. Make sure that you're following our Facebook page. We're also on Instagram, and that is at Ivy League Tutoring. And we also have a Twitter, so be sure to follow us, and we're gonna keep up with you guys. We wanna hear from you. We wanna hear where you live, what your struggles are in nursing school, so we can tailor some of our curriculum to what your needs are. So we have a texting service. Like I said, one more time, we're gonna tell you, text nursing to 85100, and be sure to follow us on our YouTube channel and Instagram and Twitter, okay? For today, I want you guys to go ahead and check in with us. I talk really fast because I'm from Texas, so you guys just try to keep up. Today we're going to try to go fast so we can cover as much as we can. My name is Amber Brown, and I'm the owner of Ivy League Tutoring, and we are located in League City, Texas. League City is a small town. It is located halfway between Houston and Galveston. We do tutoring here in our big giant facility here, but we also do Skype tutoring with students all over the nation and into Canada. So no matter where you're at in nursing school, we have something for you to help you. We know how hard it is, and we know how difficult nursing school is. And so here at Ivy League Tutoring, you won't just find tutoring services to help you get through school, but you're also going to find a family and a connection and a network of people that understand what you're going through and are here to help and to make that experience a little bit better, okay? So be sure to follow us in every kind of way that you can, and we're going to keep track of you too. If you guys have any recommendations for us, be sure to let us know. We also have a big promo going on today, so you could win a free 2-hour session. I will do a Skype session with you guys, and the way that you can enter into that is if you did a viewing party, which we talked about last week. So if you have 4 or more people from your school that you've gathered together, or from any school, nursing students that have gathered together to watch this video today and to learn and to get interactive with us, you can take a picture of you guys at the viewing party, and you're going to use the hashtag Ivy League Tutoring. You'll post that on our Facebook and our Instagram page, and we will pick one winner to win a free 2-hour session with me. I will meet you guys on Skype, of course, and we will go over any topic in nursing school that you want to go over, and we can do a free session just between me and you guys. So be sure to post your viewing videos. Today is going to be really interactive. So we're going to do a case study on heart attacks. Okay, so we had everybody last week wanted to do a cardiac video. And so this week we decided to do cardiac, and we're gonna do a myocardial infarction. And so it's gonna go a little bit more slow paced than last week, only because I really want you guys to get involved. So type to me, tell me what you're thinking, type out the answers. There is gonna be a little bit of a lag. And so you may find that there's some space when I'm kind of waiting for you guys to answer. I am only gonna put up on the board the information you give me. So if we get where we're moving along in this plane of care for a patient, and your patient doesn't have something because you forgot to draw it or you forgot to give the medicine, you'll kill your patient. we don't want your patient to die today, okay? So it's gonna be really important that you guys get involved and that you give me your answers, all right? We're always gonna go back into our plan of care and add things as you realize, like I forgot to do that and now my patient's bleeding out and I don't have a type and cross because I didn't do it. All right, so it's gonna be super interactive today. I want you guys to get in there. I'm gonna do some shout outs for people that are really just rocking this session. We had a couple of rock stars from last week. Beverly, right?
Beverly said hi.
Was a rock star, so if Beverly's
and Christopher's
here,
back.
And Christopher. So we want to hear from you guys. We want you to feel confident in giving your answers. So be sure to do that. This video will be available for you. We're going to put it on our Facebook site, and we're also going to put it on our YouTube channel. And sometimes it gets lost in the feed in the Facebook sometimes, so you guys make sure that you subscribe to the YouTube channel so that you can get really easy access to it. At the end of our session today, I'm going to have you guys tell me what you want to hear for next week. So we'll let you choose the topic. And like I said, we'll do some surprise videos during the week, so make sure you've subscribed also to our Facebook so that way you can see the videos when they pop up. We're going to do some surprise live ones for you. So if you guys have any questions, definitely let us know. We're about to get started, and I want to hear where you're from. So go ahead and type into us and let us know what nursing school you're from and where you are joining in from. I'm going to go ahead and get ready, and Casey's going to kind of get some of those things up for us. Yeah, any questions, pop them through, but please remember there is a little bit of a delay, so if we don't answer you right away, that's the reason why. So I'm going to go ahead and get ready for our MI plan of care if you guys are ready. All right.
We have another Amber in Leak City, Texas.
No way.
And we have Steph from Alvin. ACC Go Dolphins, fins up.
That's where Casey went to school.
That's right. Velez is from Illinois.
Hello, Velez.
Cassidy from Alvin, ACC. I'm telling you, Dolphin Nation.
Yes, this is serious.
Ashley from New Albany.
That's New York, huh? Hey, welcome, Ashley. Right? Yeah? Nope, just kidding. All right. Well, try.
Christopher is at College of the Mainland.
Oh,
our boy Christopher.
Hey, you can come by and see us sometimes since you're local. All right, so you guys can still let us know where you're coming in from. Let me move my cup. That way it's not in your way. All right. So how this is going to work, I'm going to drink a lot because I get really excited. I move around and I sweat a lot too. So bear with me because this is super exciting and we're going to move. All right. So we're going to start out with a myocardial infarction, what the plan of care for that looks like. We're going to start out with risk factors, what causes it. We're going to go to how you diagnose it, what the patient looks like, what's my plan of care, what's my treatment. So we're going to do a whole bunch of different things today. You may not be able to see every single tiny thing on the board. We're trying to get a bigger board so you guys can see a little bit better, but we will post the board at the end of the Facebook video so that you're able to see it and to utilize it when you need to, okay? I'm going to draw some pictures. I am most definitely not an artist. I know lots of medical stuff, but artistry was not a God-given talent. So please bless me and just understand that when I draw something on the board, everything just somehow ends up looking like a deflated water balloon. So I will tell you what I'm drawing, but we may do that. So what I'm going to start with is, we're going to start with how this whole thing starts. So myo means muscle, right? Cardial, heart, and infarction, meaning we're not getting blood flow, we're getting some necrosis, and this is going to end up dying at some point, okay? I actually think, Casey, come over here with me. I'm going to talk about the heart really quick. If you don't understand the blood flow through the heart, you're really going to have a hard time understanding what a heart attack is, okay? Now, this is a prenatal heart, so we're going to ignore this side. This is a postnatal heart. This is what normal adult hearts look like, okay? So normally what happens is you've got blood flow that's going in the body. The veins, right, are going to bring blood flow back up to the body. They're going to go through the superior vena cava. You guys should be able to walk through this nicely. You should know this by now, but we're going to go over it just in case. It's going to go into the right atrium, through the tricuspid valve, into the right ventricle. The right ventricle is going to contract, sending our blood up the pulmonic valve, into the pulmonic artery, and into the lungs. The lungs' job is to oxygenate our blood. It's going to bring it back into the heart through the pulmonary veins. The pulmonary veins are then going to go into the left artery, left atrium, and then that's going to go through the mitral valve and into the left ventricle. That's then going to go up the aorta and out to the rest of the body to give oxygenated blood. Now, this is how the heart works, right? This is the heart's job. But the heart in and of itself is an organ, so it's necessary for the heart to have blood flow, right? It has to have its own blood supply. This has nothing to do with what's going on inside of here. This has everything to do with what's going on the outside. So the heart, we know, is a muscle, right? All right. So if it didn't have strong enough muscle contraction, it wouldn't beat and none of this would work. So what supplies blood flow to the heart muscle. That's what I want to hear from you. Who's first? I know there's a lag. Just bear with us. It's going to work. Ooh, either nobody knows or there's like a really significant...
Amber says coronary arteries.
All right, Amber who?
Lewis.
Amber Lewis. Nice work, Amber. That's right. So our coronary arteries are actually on the outside of the heart, and arteries are always going to bring oxygenated blood to something. When we bring oxygenated blood to something, that's called perfusion, right? And so the coronary arteries actually live on the outside of the heart. It has nothing to do with what's going on inside here. And the coronary arteries are going to give blood flow to this muscle. If I don't have blood flow to the muscle will die. It will become necrotic and the heart will no longer work. So that is what we're going to be talking about when we talk about a myocardial infarction. It really has very little to do with what's going on in here and more what's going on with the outside of the heart. Then once this heart muscle is taking a hit, it's got some bad things going on to it, right? Then the inside of the heart is also going to be affected because that's what the heart does. All right, so follow me back over. All right, you're going to come over this way. All right, so I want you guys to start telling me while I'm drawing up on the board, I want you to tell me some of the risk factors that are associated with an MI and give me the reason why those risk factors are. I want a rationale. Everything that you give me today has to have a rationale. If you can start getting yourself ready for that in nursing school, no matter what your answer is, providing yourself with a rationale, your test scores are going to go up way higher than you would expect. No guessing, all right? So let me know what the risk factors are. We're going to talk about why each one of those is a risk factor.
Becky says smoking.
Why is smoking a risk factor? Let's talk about what our vessels look like. That is absolutely right, Becky. So what does smoking do that gives us a hard time? This is our vessel here, okay?
She said constricts vessels.
All right, that is one thing that it does, absolutely. So here we have our vessel here, right? The most common cause of an MI is... I'm going to draw it while you guys are chatting. Okay.
Plaque buildup, causing a blockage.
Plaque buildup, and that is called atherosclerosis. All right? So
and Amber said she said
Amber
that.
Lewis again?
Amber Lewis is on it.
Top of it today. All right, so this is my vessel. This is a buildup of plaque, and this plaque is made up of all different kinds of things. The plaque would be made up of fats, of cholesterol. We have poor diet over a long period of time, right? And so that's going to build up in our vessels. Well, now how much blood flow do I have that's coming through here? Not very much. So what's my biggest risk? Okay? My biggest risk here is going to be that I'm not going to be able to get good blood flow, right? Or I'm going to clot this off. So what you're telling me is that smoking, right, is one of the things that can cause that or can make this worse. So if smoking is a risk factor, you said one thing that it does is that it vasoconstricts. So what would happen if I vasoconstricted this is that this would completely clot off. We don't get any blood flow at all. And that's going to give us a myocardial infarction. That's going to give us a heart attack because there's no blood flow, right? So in a myocardial infarction, what happens is we get the buildup of atherosclerosis because of poor diet, cholesterol, right? The smoking can vasoconstrict that, so that can be an added risk factor for us, right? But since we already talked about what the plaque is built up of, we know that this can also be caused by high cholesterol, right? It can also be caused by high triglycerides, right? Let's talk about cholesterol for 1 second. There are two different kinds of cholesterol. Tell me what the two kinds are and which one's good and which one's bad. And triglycerides are our fats, right? So we've got smoking that's going to vasoconstrict. While you guys are out talking about cholesterol, I'm going to finish talking about smoking. So the smoking is going to vasoconstrict. It also gets lots of chemicals inside your body, right? When you get chemicals that are foreign, it causes a huge inflammatory response, right? And that inflammatory response can cause some irritation inside the vessels and some thickening or hardening of the vessels, which is going to lead to further atherosclerosis or arteriosclerosis, which is the hardening of the vessels. Did anybody get back about cholesterol? What do we got?
HDL good, LDL bad.
All right, so HDL is good and LDL is bad. And let's talk about that for a second and why. So HDL is what we call the good cholesterol. And why is it good? Well, does anybody know what organ cholesterol is synthesized in?
Amber with liver.
Amber, you are on it today. All right, so the liver is responsible for synthesizing cholesterol. So what the HDL does and why it's good is that it goes out into your vessels, it snatches up some of this cholesterol, it's going to pull it back to your liver and allow that to be excreted out of your body. That's great because it's cleaning out your vessels. The LDL does not do that, all right? The LDL just goes and deposits itself. It's lazy. It just goes and just lays inside your vessels and does nothing, okay, and just lays there and forms all this atherosclerosis, which eventually can end up giving us a clot, all right? So high cholesterol, high triglycerides, which is our fat, that's all going to build up in here. Does anybody else have any risk factors for atherosclerosis? Smoking, we talked about vasoconstriction and irritating of the vessels and arteriosclerosis. What else we got that's a risk factor for atherosclerosis or for an MI?
We had high blood pressure and diabetes.
Yeah, so let's talk about hypertension. So hypertension is most definitely a risk factor, and here's why. So if I have this buildup inside of here of all of this gunk, okay, and I've got high pressure pushing through here, every single time it pushes on this area, it's rubbing on the inside of the vessel, all right? Now say I took this pin like this, and I rub right here. Well, right now it's not bothering me at all. But if I do this all day, every day, it's eventually going to cause some skin breakdown here. My body's going to recognize something's wrong with my skin, and it's going to send a huge inflammatory response. When the inflammatory response comes out there, what does it bring with it? What happens in the inflammatory response? What's your body going to bring in with it?
Amber with white blood cells.
White blood cells is one of them. Yes, it'll send a bunch of white blood cells out to the area. It will also send platelets out, right? So the platelets are going to come and aggregate. You guys have heard of anti-platelet aggregators. And
Christy
we'll
with
talk about,
platelets.
Huh?
Christy with platelets.
Christy, nice work, Christy. So the platelets are going to come out and aggregate around here. Now how much room do I have in my vessel to get stuff through? We barely have anything. So this patient is almost completely clotted off. And we're about to have a really, really hard time with this patient if we can't get any blood flow through. So back to the hypertension. So the hypertension is irritating, right? And that's going to cause an inflammatory response. Platelets are going to come and aggregate. Now, we're in big trouble, all right? Diabetes was another one you guys had mentioned. So let's talk about diabetes. So diabetes is too much blood sugar, right? Either too much blood sugar or too little insulin. Blood sugar makes our blood more thick, more viscous, and so that's already going to put us at more risk of a clot. Having thick and viscous blood also increases our blood pressure, right? Think of your vessels like a water hose. If I'm pushing water through, that goes through rather easy and my pressure's normal. If I'm having to push peanut butter through a water hose, I'm going to require a lot more pressure in order to get that through. So their blood becomes thick, increased viscosity, high blood pressure has to come through here. Now I've got hypertension, I've got diabetes. I also have all this sugar that likes to gather around this area, and before we know it, we have no blood flow going through that area. And a lot of patients will have several of these all together, and that's going to be a recipe for disaster in our patients. Yeah? Any other risk factors that we missed? Nobody else? How about a sedentary lifestyle? Okay? So
that was mentioned several times.
Ah, yes, very nice. All right, so sedentary lifestyle, which usually happens a lot in nursing school because you just sit around and have to study all the time, right? So a sedentary lifestyle means I just am not exercising very much. And the reason why that causes us a problem is because when we exercise, our HDL increases and our LDL decreases. So if you're not exercising at all, you're building up a ton of bad or LDL cholesterol, and you're decreasing your HDL. So that's going to cause a lot of buildup in our vessels, and that's going to give us a really, really hard time. If you guys have a hard time remembering your fasting lipid panel, I'm going to go over that really quickly with you, your levels. So if you see something that looks like this, it's an FLP, then that means it's a fasting lipid panel. You definitely want your patient fasting so you can get accurate records. Anybody know what's included in an FLP? Do not look at my board. Okay.
Claudia said triglycerides. Amber says cholesterol, HDL, LDL, and triglycerides.
Very nice work, everybody. All right, so easiest way to remember these, put them in lines of 50. If you can put them in this order, then you can just go down by 50 every time. So we have 200, 150, 100, 50. Okay, that goes down by 50 every single time. Total cholesterol, you want, oh Lord, less than 200, right? Triglycerides, we want less than 150, yes? LDL, we want less than 100. HDLs, we want greater than 50, since those are our good ones. So these are easy to remember. If you just put them in 50s, put them in the right order. All right? So we've got smoking. We've got high cholesterol. We have high triglycerides. We've got hypertension, diabetes, sedentary lifestyle. This is a recipe for all of this clotting off. Okay? So now what has happened is I've kind of vasoconstricted a little. Lifestyle choices, some disease processes are causing this not to be able to get blood flow. So what happens, this goes to our coronary arteries, right, which we talked about on the other side, are what gives our heart its perfusion. And perfusion means it's getting oxygen so it can do what it needs to do, all right? So these arteries here, the coronary arteries, are almost blocked. So my heart's going to end up being over here, right? You like how I drew a heart that looks like it's broken? Lord help me. All right. So now I'm not getting any blood flow to my heart muscle. How will that feel in your patient? What's that going to feel like? There is a term that we use for how it feels. So tell me what the term is. Anybody?
Deborah says angina.
Angina, there we are. All right,
and
so
Steph.
Angina means that we have chest pain. All right, so angina just means chest pain. It's a gritty, weird word, but that's what it means. There are two different kinds of angina. Tell me what they are. Don't look. Anybody? You cheated, I can feel it. Stable and unstable, yeah? All right. So let's talk about the characteristics of stable angina. So I like to think of this as like somebody that you're dating, all right? So if you're dating somebody, you're wanting them to be stable, right? Which means that they are predictable. You know exactly what they're going to do, when they're going to do it. If they say they're going to call, they're going to call, right? We want unstable, it is going to, the pain, which is angina, is going to go away, right, with rest. Now, I know that you love your significant others, but sometimes you want them to go away and so you can have your own time. And so with stable angina, it does go away with rest, or it goes away with nitro, all right? So let's talk a minute about nitro, all right? We're going to come back to this whenever we go through the full plan of care. But really quick, we know that nitro is a vasodilator, all right? And so if we are going to vasodilate this, right, then that should make us be able to open up our vessels enough to get perfusion to our heart muscle, all right? So it should go away with rest or nitro. It's predictable. Give me some other characteristics of stable angina.
Steph LeBlanc's been getting all these answers right, too.
Steph?
They've just been coming in as you've been doing.
Ah, okay. All right. Nice work, Steph. Anybody else know? All right, so the last one is that it lasts for less than 15 minutes, right? So what I'm going to expect is if I get up right now and I run across the street, okay, yeah, I'm going to be really tired. I'm probably going to have some chest pain, but if I sit down, I relax, I get a snow cone, it should go away, all right? So our boyfriend over here is predictable. He calls when he's supposed to. He goes away when I need some alone time. He stays for a little bit, and then he realizes, like, yeah, let's give her some time, all right? Unstable, these are the people you don't want to date, okay? So they're not predictable. You never know when they're going to call. They say they're going to, but then they don't. They don't go away whenever you need them to, okay? So it doesn't go away with rest or nitro, and it usually lasts longer than 15 to 20 minutes. This can happen at rest, okay? So I'm just sitting here hanging out, and all of a sudden, I have unstable angina, okay? So how would you know the difference between unstable angina, because this is chest pain that doesn't go away, and an MI? Unless you guys think on that for a second, I'm going to come over to the other board and get ready for our plan of care.
Chrissy said do an EKG.
All right, we could do an EKG. So you're telling me that the patient's going to need to come into the hospital, yeah? So if the patient has unstable angina and it's not being able to be relieved, then we need to send that patient into the hospital for a full cardiac workup, all right? So what I'm going to do is I'm going to give you guys a case study on this guy who's coming in with a supposed MI, and I need you guys to save his life, okay? So I'm going to tell you what he looks like when he comes in, and you guys are going to roll in with what you're going to do for each section. I'm going to guide you through each one, all right? So we've already talked a little bit about the patho of MI. We know that it's caused by atherosclerosis, hypertension, diabetes, smoking, sedentary lifestyle, high cholesterol, high triglycerides, all right? So what you have is you are a triage nurse that works in the hospital. You're in the ER, all right? You're in charge. You're the boss, all right? Whether you know anything right now or not, you're the boss. So I need you guys to help me save this patient, all right? You have a 57-year-old male that comes into clinic. He comes into the hospital, comes into triage, and he is just complaining of chest pain. Man, I got chest pain. That's the only information you're given. I want you to tell me what questions you're going to ask him and what immediately you're going to do for this patient. Not long term, right now as he's coming to triage. Because we only have 30 to 45 minutes from when he just walked in to get him into cardiac cath lab. That is a standard across all of the emergency rooms, all right? So you guys, we only have half an hour, so let's get on it. Tell me what you're going to do for this patient, all right? 57 years old, you're probably going to want to know a couple of questions. You want to ask him some things, but you also want to move pretty quickly.
When did it start?
All right, you want to know when it starts. And this young man, says the chest pain started about, I don't know, maybe about 2 hours ago. So, chest pain for 2 hours. What else you guys got?
Describe the pain.
Describe the pain. It's crushing pain. It feels like an elephant sitting on my chest.
We have EKGs.
All right, so part of our, let's talk about our symptoms, and then we're going to do our diagnosis, and we're going to do our treatment. So I'm going to put that down here in part of our diagnosis. We are going to want to get an EKG immediately on this patient. We're going to talk about that in a minute. What else do you want to ask this patient?
Cassidy says, what were you doing when it started?
What were you doing when you started? All right, so let's say that this is Mr. Jones. All right, so Mr. Jones comes in, said he has this crushing chest pain, feels like an elephant sitting on his chest. I mean, I was just sitting at home watching Jeopardy, and all of a sudden, I got a little excited, and I started feeling the chest pain, and now I'm here. What else you got? Don't make me act like that again, okay?
Has this happened before?
Yeah, it's happened lots of times before. You guys probably remember me.
Does anything relieve it?
Well, I'm here, aren't I?
Have you taken any meds? Nitro, was it effective?
Oh, yeah, I took one of those little pills. Those little pills, I think, that the doctor told me to put up underneath my tongue, and I took 2 of those, but didn't do anything but give me a darn headache.
They want history and family history.
Well, my dad had some heart problems. Not sure exactly what those look like, and I've been in here lots of times. I think I had a heart attack, maybe, I don't know, once or twice before.
You taking any over-the-counter meds?
What you mean by over-the-counter? You mean like things that the doctor didn't give me a prescription for? I take a little baby aspirin, like a little one that a little baby would take. I take that every day just to make sure that my heart stays good.
When was your last meal, and what was it?
Ooh, my last meal, I ate some wicked pizza last night. Hadn't eaten anything this morning, and I felt like I had a little bit of indigestion. Got some nausea going on. All right, anybody want to ask about any other symptoms? Let's talk about symptoms of an MI. What did you hear him say that you think is indicative of an MI? All right, I'm going to write a couple of them up on the board while you guys are hammering them out, because we gave you a pretty good history.
Do you exercise recently or regularly?
Oh, exercise. We need to ask about that too. And no, he does not, but he does enjoy Jeopardy daily. All right? So what we know so far is he said that he has crushing chest pain. You guys keep rolling in with the answers while I'm writing. He said he has crushing chest pain, right? Feels like an elephant sitting on his chest. What are some other symptoms that we need to ask if he is happening right now? He also said he had a pretty good family history of cardiac problems. He said that he's felt kind of some nausea and maybe a little bit of indigestion, and that can sometimes look like a heart attack, and people can think that they're having indigestion.
We have some other good questions like allergies. How much do you weigh?
Yes, we definitely want to ask allergies. I'm going to put that up here because that's going to come into play in a little bit. Are there any specific allergies you want to know about? So I'm going to put that down here.
Radiating pain.
All right, so usually...
Jaw, arm, dizziness, lightheaded.
Yes, dizziness, lightheadedness. You guys are coming in with some good stuff. So they can feel dizzy, they can feel lightheaded. And do you know why? Your heart is not pumping well. If you're having an MI, you're lacking blood flow to the muscle. When you lack blood flow to the muscle, your heart is not going to be able to pump effectively. So it's either going to be pumping really fast and really disorganized, or it's going to be pumping really, really slow. Either way, whether it's significant tachycardia or major bradycardia, your cardiac output is still going to be decreased, okay? And I want you guys just to kind of verbalize why, but I'm going to walk through that process as you're kind of thinking about it. So normally what our cardiac output looks like is stroke volume times heart rate, right? So our stroke volume is how much our heart is putting out per beat. You multiply that times beats per minute, and that's going to give us how much blood is coming out of our heart per minute, all right? So in these patients, they're going to have very poor cardiac output, because if they have slow heart rate, then that's going to cause us to have a decreased cardiac output. If they have super, super fast heart rates, even though it's faster, there's less filling time because it's going too fast. So the heart is pumping, but that makes an ineffective pump, all right? So either way, and you may see either in an MI, they may have significant bradycardia or they may have significant tachycardia, all right? So we've said they have crushing chest pain. We said it's radiated pain to the left arm, right? What is different in women's symptoms of MI versus a man's?
For the allergy answer, we've gotten a lot of the iodine and latex.
All right, so you want to
Great
check
job, guys.
All right, I'm glad you guys said that. That's going to come into play in just a little bit.
Because they said you're going to have dye.
Oh, nice. You guys are thinking ahead. That is beautiful. And that's exactly the reason why I put this up here and we're doing the whole plan of care. You as a nurse have got to learn to get ready for what's coming. You have to anticipate, because we don't want to be running and taking that patient's labs multiple times or forgetting something, especially when we have this little amount of time. So you said allergies to shellfish and iodine, all right?
And latex.
All right.
And then everybody says atypical symptoms in women.
Okay. So women usually have, did anybody say anything atypical? Jaw pain?
Yeah, jaw pain.
Yes.
Oh, Stephanie came in clutch with the are they on metformin?
Ooh,
my word.
Wicked. Oh, that was good. I'm going to write that down here because, that was nice.
Jessica says dental work lately.
Oh, very good. How come we're looking for that? Dental work can sometimes cause endocarditis, right? So we want to watch for that too. Women will usually have jaw pain, breast pain. They can just get very nauseated. They can have referred shoulder pain. So it can look very, very different, and it may not even be excruciating chest pain. So if I woke up in the morning, I'm making breakfast for my kids, and all of a sudden I just feel kind of nauseated and my shoulder hurts, I think like, well, I probably haven't eaten anything, and all those workouts that I've been doing have caused some shoulder pain, right? And so sometimes women will really miss out on some of those signs and symptoms of an MI, and we won't find out until the heart has already suffered a significant damage. So you guys have told me so far, signs and symptoms of an MI. We've got crushing chest pain, we got family history, nausea, indigestion, dizziness, lightheadedness, pain that radiates to the left arm. How are they breathing? Nobody's talked about breathing yet.
A lot of people talk about shortness of breath.
All right. So dyspnea is what we usually see. They're short of breath. They're also, how do you think they feel? They're very, very anxious, because if you have crushing chest pain, that tells you like something is really, really wrong. And so their anxiety can kind of be out the roof. So we really need to do our best to use a therapeutic environment, therapeutic communication, get the patient calmed down as much as possible, all right? So now that we kind of have a history on this patient, now he was just sitting down watching TV and this pain just came out of nowhere. So what kind of angina was he having?
Oh, Christopher says the feeling of impending doom.
Oh, they sometimes can get that. Sometimes you'll get that with a pulmonary embolism, but sometimes they can feel like something very, very, very bad is happening, and that can cause them to be more anxious, and then they will get not only dyspnea, but they can also get tachypnea, right? And then we will either see, like I said, we'll either see bradycardia or tachycardia. So just look for changes in the heart rate.
Everybody coming in clutch with unstable angina.
Yes, all right. So this patient is unstable angina, so we had to bring him into the hospital. So with unstable angina, remember that we want to teach them to take nitroglycerin, which is our vasodilator. They need to take that 2 times, and it goes underneath the tongue, sublingual, right? So it's going to go underneath the tongue. Make sure that the patient is sitting down, right, whenever they're taking it. Because if you're majorly vasodilating, what's going to happen to your blood pressure? It's going to tank on you. You do not want them to fall and hit their head, and we have to deal with that on top of an MI. That's not going to fare well for your patient, all right? So make sure they're sitting down. There is one big giant side effect of nitroglycerin that everybody complains of, but we don't do a whole lot about. It's not something I would immediately call the physician for. What's the number one side effect that people complain of with nitroglycerin?
Headaches.
Yes. And so we typically will just have them take Tylenol, and they're probably taking an aspirin at that point anyway. And so for these patients, we just say, okay, the headache is kind of an expected thing because of the vasodilation. Hang in there, all right? Hypotension is another thing that definitely happens, all right? And sometimes they can get reflex tachycardia, so watch out for that too, all right? So make sure the patient is sitting down. So with nitroglycerin, we have them take one and wait 5 minutes. They take another one, call 911, wait 5 more minutes, and then take the third, all right? Do we need to say it again? Are we good? I think we're good. All right. So you guys know how to instruct your patient to take nitro, and I'm going to come back and talk a little bit more about nitro whenever we get to giving that to our patient. So somebody said earlier we need to go ahead and do an EKG. Are there any other tests, diagnostics, labs that you want to run on this patient? Or give me your basic nursing care. What are you going to do for this patient as soon as they come in? We've hooked him up to an EKG, all right? Poor Mr. Jones, we look on the EKG, and lo and behold, guess what we see? We see a STEMI. All right, so somebody needs to tell me what a STEMI is and how it is significant to an MI. While we're doing that, and some people are working on that, talk to me about any labs you want to draw. Give me some diagnostic tests that we want to do for this patient. You could also jump in with some nursing care if you want to do that too. All right.
CKMB, troponin.
Oh, yes. All right, so we're going to do a CKMB. We're going to do a troponin. We could also do a CK, right? All right, so we've done an EKG, and this came out with a STEMI. Now, a STEMI means, anybody come through?
ST elevation.
ST elevation MI. So where your normal EKG is going to look like this. Here's my P wave, my QRS, and my T, right? Your patient is going to have a P, QRS. It looks like if you're looking at it from the side, they call it a fireman's hat, okay? So this is called an ST elevation. It is very indicative straight up of an MI.
Straight
up. If the patient does not have a STEMI on their EKG, could they still be having a heart attack? Absolutely. Because there are lots of different ways that your heart can look in different spots that you're having the heart attack, all right? So just because a patient doesn't have a STEMI does not rule out an MI. We're still running trying to get this patient treated, all right? So we're definitely going to do that. We see that this patient has a STEMI. That makes me a little bit nervous, right? I'm not really liking the way this is looking. I'm thinking poor Mr. Jones is having an acute MI. So somebody told me we're going to draw CK and B, troponin, and a CK. These are called our cardiac enzymes, right? And so if I see that there's some abnormalities on the EKG, or even if I don't, I'm still going to run my cardiac enzymes. Does anybody know what the CK and B, the troponin and the CK are testing? They are enzymes, all right? But what do they test and why are they significant? Well, it looks like up here I put a CK and then a CK and B. Does anybody know what CK stands for? Tell me what you know about CK and CK and B, and then we're also going to talk about the troponin, okay? So these are what we're going to draw as cardiac enzymes, and you guys
got some Ddimer up here.
Oh, we want to do a Ddimer. I'm going to write that up here too.
CBC.
Yes.
Lipid panel.
Yes. Anything else? So the CK
muscle damage.
Muscle damage. Yes. So the CK is called creatinine kinase. All right. Anytime you see an ACE on something, that typically means that it's an enzyme. So creatinine kinase is released whenever you have any muscle damage anywhere in your body. Let's say the patient has muscular dystrophy and their body is rapidly destroying their muscle. They're going to have an elevated CK. So all the CK tells me is you have muscle damage somewhere, but it doesn't tell me where. So in a patient with an MI, of course, the CK is going to be elevated because I have heart muscle damage, right? But the difference is that we're going to add a CKMB. The MB stands for myocardial bands. And so this gives me, is there muscle damage specifically in the heart, all right? So this one is going to be much more indicative of a heart attack than the CK will be, all right? Does anybody know when the CKMB elevates and how long it takes or how long it stays in the body? And then let me know when the troponin elevates and how long it stays. Our typical gold standard for cardiac enzymes is the troponin. And the reason for that is because the troponin increases the quickest and it stays the longest. And so whether the patient's been complaining of chest pain for 2 hours or whether they've been having chest pain, kind of on and off for the last couple of weeks, it usually is still going to show an elevated troponin, all right? The CK we know is going to be elevated. There's another test that we can do that tells us that there's general inflammation, and that's our ESR and our CRP. And those are two markers of inflammation. ESR is an erythrocyte sedimentation rate, and the CRP is a C-reactive protein. Both of those are indicative of inflammation somewhere in the body. Well, my heart's pretty mad right now, right? So chances are our ESR and our CRP are probably going to be elevated, all right? Did anybody get back to us about the CKMB and the troponin? Not yet.
4 to 6 hours.
Okay, so 4 to 6 hours is typically what we see for the CKMB. Troponin can increase in an hour. So you can see its first increase in 1 hour, and it can stay elevated for 10 to 14 days. These are the patients you see that will say, I've been having chest pain kind of since last week, and they come in to see their primary care doctor, and their doctor says, you had a heart attack last week. And how would I know it was last week? Because my troponin is still elevated, but my CKMB has become normal. So a CKMB will elevate in 4 to 6 hours, but it's only going to stay elevated for about 72 hours, all right? So if my troponin is elevated, my CKMB is normal, that tells me that I've probably, then I probably had a heart attack within the last maybe 4 to 14 days or so, okay? So these are helpful in helping us see how long has this been going on. Because if we've been losing oxygen and perfusion to our heart for a long period of time, that heart muscle is going to die, all right? So let's kind of walk through what that process looks like really quickly, okay? I'm gonna grab this marker over here. So what this looks like, and the reason why we get so nervous about myocardial infarctions and we want to move really fast on them, okay, is because your heart is losing perfusion, right? Your heart is losing blood flow. There's a clot of some sort, right? And so if we are losing that, we get what's called ischemia, all right? So ischemia means we have low blood flow, right? The ischemia, if we let it continue without fixing the problem, that's going to lead to an infarction, which means I'm not getting any blood flow. If I'm getting no blood flow and no perfusion to the heart muscle, that is eventually going to lead to necrosis, all right? Necrosis means death of the tissue. When we have death of the tissue, lots of white blood cells and things come out there, and it eats that tissue, and then it forms scar tissue in its place. And the problem with that in the heart is scar tissue, one, does not move. And we know our heart moves a lot. So if scar tissue doesn't move very well, then our heart's going to be a little constricted as far as pumping, and it's not going to be a very effective pump. All right, so necrosis is a bad idea, right? We want to try to prevent that. The second thing that necrosis can cause, other than not stretching, is that scar tissue, you cannot conduct electrical impulses through scar tissue, okay? So when the heart's trying to fire off with its electrical activity, it's not going to be able to fire through that scar tissue. So if the scar tissue is anywhere around the SA node or the AV node, we're going to have major dysrhythmias and conduction problems. So this is what we're trying to prevent. So this patient right now has already gone from ischemia to infarction. We're trying to prevent the necrosis, so we need to move rather quickly, all right?
And we have BNP and BUN.
Nice. All right, so, somebody just saved their patient's kidneys.
Mm-hmm.
Oh, who was that? You know?
Stephanie Fisher.
Nice work with the BUN and creatinine. What was the other one? A BNP?
Mm-hmm.
BNP. All right, so we understand cardiac enzymes. So we know troponin is going to be the first on the scene to elevate. It's going to stay the longest. CK will be elevated for a little period of time. CKMB starts in a couple hours, 4 to 6 hours. It's going to stay for a couple of days. So we're going to use those to find out how long your patient's been having a heart attack, all right? We talked about ESR and CRP are going to be elevated. We talked about doing a fasting lipid panel. I need to know if my patient's triglycerides are high, if their cholesterol's high, if their HDL and LDL are high or low, depending on which one, right? That's going to tell me is my patient probably have atherosclerosis, and that's the cause of this problem. We're also going to draw a Ddimer. Does anybody know what a Ddimer is? And I also want you to tell me what a BNP is, because those are some of the ones that students tend to forget about. Stephanie mentioned the BUN and the creatinine. This is super important because kidneys are vital in our patients, right? So what we talked about earlier was that your patient having an MI is going to have low cardiac output. My worst case scenario of low cardiac output is poor perfusion to my organs, and my organs can end up dying, not just my heart, right? So my heart, it's not working very well, it's not pushing blood out, and blood's job is to go through the arteries to the other organs and keep them perfused. The first organ that always takes a hit is the kidneys, okay? And so that's one reason why we need to do a BUN and creatinine, is to make sure our kidneys are getting perfusion. That tells me, okay, my patient's not in cardiogenic shock, my patient's still getting blood flow to the kidneys, so my cardiac output is adequate enough to perfuse the kidneys, okay? So that's one reason. We're going to talk about the other reason here shortly, all right? Did anybody say what a D-dimer was or a BNP?
D-dimer for coagulation. Can rule out a blood clot.
Yes, so a D-dimer can rule out a pulmonary embolism. That's a blood clot in your lungs, right? And some of these signs and symptoms can look like a PE. And so the D-dimer will help us to determine if this is caused, if these symptoms are caused by a pulmonary embolism or if they're caused by a myocardial infarction, okay? The second thing that we talked about is a BNP. Did anybody say what a BNP is?
Previous heart damage, CHF.
CHF. All right, yes, it does monitor CHF. So BNP, you'll see it called different things in different texts. It's either a B natriuretic peptide or a B type or a brain natriuretic peptide. You'll see it called lots of different things, okay? The BNP is an indicator of heart failure. So what the BNP is it's an enzyme that is released not from heart damage, but from heart stretch. So in cases of CHF, right, where your heart is stretching really, really big, when your heart stretches because it can't accommodate all that fluid volume, it releases the BNP. So anytime your BNP is over 100, that's indicative of heart failure. So this is making sure that your patient doesn't have CHF, your patient's not in heart failure. That's why we're drawing the BNP, all right? The CBC we're drawing because MI symptoms can really mimic a lot of different things. It can mimic, some people will say they have really bad chest pain and it ends up being a pneumonia. Or some people will say they have really bad chest pain and it ends up being asthma or some kind of virus. And so the CBC will give us an idea of white blood cell count, so we can see if the patient has an infection. It will also tell us what their platelet levels look like, because we may need to put the patient on something like that later, okay? And the CBC will tell us if the patient's anemic. It'll give us an H&H. So it's going to give us a lot of indications of kind of what's going on in the full picture of our patients, okay? You guys are missing a really important lab that nobody has said yet, so if anybody wants to pop in, Casey will jump out at me whenever we're talking, all right? So you guys have already said an EKG. We're probably going to want to do a chest x-ray, right? And I would want to do a chest x-ray to see first.
Type and screen.
A what?
Type and screen.
Oh, we are going to need that. So you missed two things. All right, so we're going to do a type and screen, and that's because our patient is about to go into cardiac cath, and we're going to talk about that.
ABGs.
Oh, ABGs, yes please. So ABGs will tell me if I am in any acid-base imbalance.
CMP.
That's the one I was looking for. So the CMP is a comprehensive metabolic panel. I need to look at my electrolytes, because if my potassium or my calcium are high or low, that can cause me to have dysrhythmias, right? And we're having a lot of muscle damage, and so sometimes that can release some potassium and things like that too. So we really need to check electrolytes on this patient. I'm going to do a chest x-ray, and that's going to rule out infection. We're going to see if the heart is also enlarged, which is called cardiomegaly, right? So I need to do a chest x-ray. I've done an EKG. We've run some
Echoes.
labs. What's that?
Echoes.
We might do a quick echo if we have time, all right? And so an echocardiogram is basically like a ultrasound of the heart. And so we're going to look at the blood flow and see who's getting what, all right? So if we have time to do an echo, we will. But if we only have 30 minutes, we're sometimes in a really big hurry to move, okay? And so some of the echo can wait till when we get into cardiac cath lab, because we're going to be looking around in there anyway, all right? Okay, so we've done lots of diagnostic tests for this patient. Hopefully you guys covered everything, because you're going to need it to get this guy into cardiac cath, right? So let's talk about pre-op and post-op cardiac cath. Or tell me, what is a cardiac cath and why do we do it? And then give me any nursing interventions that you know for pre or post. Also, you have given your patient no medications. So poor guy's probably laying there in really significant pain. So if you want to shout out some meds that you maybe want to give to your patient, or I don't know, maybe start an IV on your patient. Let's do that.
Yeah,
too,
somebody said start
guy,
two IVs.
Yeah, all right. So you finally got an IV started on your patient. He's already complained to the nursing board. He's already complained to the charge nurse because he hasn't had any fluids, and they told him he couldn't eat. So that's going to have to be one big strike for us right now. But we can come back from this. Right?
And they've said Mona at the beginning, but we weren't at that point.
We did get it at some point. All right. So somebody said Mona. We can talk about that. And then I want you guys to shout out any other medications that we're going to give. So let's talk about Mona first. So the M in Mona is for morphine. And the morphine serves two different purposes. One is for pain, right? Of course, they're in horrible pain. Morphine also has a little bit of a vasodilating effect. And so that can help us with the heart. All right. O is for oxygen. So if our patient is hypoxic, we definitely want to put some oxygen on. N is for nitroglycerin. You're going to make sure you're putting them on a drip, all right? So we need to do a nitroglycerin drip. That is a vasodilator, all right? Make sure that the patient is in bed, that you have checked the blood pressure, because remember that nitro can greatly decrease your blood pressure, all right? But we do need them on a drip to keep those vessels nice and open so that we don't have another clot, right? All right, and the A is for aspirin. So a lot of people think that aspirin is a blood thinner. It isn't. Can it kind of thin your blood a little bit? Maybe, but that's not its job or its purpose. It is not a blood thinner. Aspirin's job is an antiplatelet aggregator. And like I drew the picture on the board earlier where the atherosclerosis was building up and the platelets formed all around it, that can help the platelets from not forming. They just get slippery and they don't stick together and they keep going through the blood vessels. All right? So we've got morphine, oxygen, nitro, and aspirin. Are there any other drugs we need to give this patient?
We have some pre-op checks.
All right, go ahead. Let's wait on that one. We're going to finish the medicines real quick and then we'll come back to this. Because you got to get this guy his meds before we go in, right? And then we'll go back to pre and post. So we know what's going on with our patient. They're in pain.
It said anti-anxieties.
Yes, let's give some benzos or some kind of anti-anxiety to our patient, because if we can calm down our patient a little bit, maybe we can bring down that tachycardia enough so where the cardiac output can increase a little bit more. All right? Since we're not getting great cardiac output, sometimes that fluid can back up either into the rest of the body or into the lungs. So we need to do something to help get rid of that fluid. So we will either give our patients a diuretic, such as Lasix, and that's going to help to get rid of some of that fluid, help the workload of the heart a little bit, all right? We can also give ACE inhibitors, right? So ACE inhibitors we typically think are a cardiac drug, and it does, in the end, help the heart, but these are really kidney drugs. So ACE inhibitors will help to pull fluid to the kidneys. One thing that does that's awesome is it gives the kidneys perfusion, and remember, kidney perfusion is always going to go first if we're going into cardiogenic shock or the patient is really not doing well, all right? The second thing that it will do is to get rid of fluid so that the heart isn't having to work so hard when it's already hurt, okay? What else are we going to give this patient? We've got morphine.
Beta blockers.
Beta blockers or
Statins.
calcium channel blockers. All right. So beta blockers and calcium channel blockers, we always want to think of those similarly, and they do two things. One thing that they do is to decrease the heart rate. The other thing they do is to decrease the blood pressure. Calcium channel blockers typically work a little more on blood pressure, and beta blockers work a little more on the heart rate. So depending on what's going on with your patient, we're probably going to choose one to just chill out your heart a little bit. Because when they're having an MI, their heart's realizing, I'm not going to get any oxygen, and so it may be doing like funky, weird things, all right? So choose a beta blocker or a calcium channel blocker. If you're going to give them together, be very cautious of the heart rate and the blood pressure. If the heart rate is less than 60, be very cautious about giving the beta blocker, all right? If the blood pressure is less than 90/60, be very cautious about giving a calcium channel blocker, all right? So usually we're going to pick one of those since they do similar things. So we've got morphine, oxygen, nitro, aspirin.
Jenny says check your potassium because of diuretics.
Oh, yes, definitely check your potassium because of diuretics, and we already have some heart things going on. So I'm going to include that in my nursing plan of care too, right? We're going to keep checking that potassium, okay? All right? Okay, we've given our patient lots of medicine so far. We need to put them on some IV fluids. We have 2 large bore IVs. That's what I've already heard. I haven't heard any other medicines. Is there anything that I missed?
Statins.
The statin. So the statins we'll send them home on. Statins are medications to decrease cholesterol and to decrease triglycerides sometimes too. And that's going to help to prevent things long term. This is not an acute medicine that we give to immediately treat. It is something that we're going to give the patient. And remember, we always want to give statins at nighttime, okay? But it's not an acute medicine that we need to give right now, okay? So that's something we are going to put on it. You guys missed a couple of really important medicines, so you can shout them out to me, hopefully before we get to a point where you would have already needed them, okay? So we're going to check our potassium. We got this patient. We're giving all these medicines. We've got morphine going and nitro and...
Muscle relaxers.
Oh, sometimes we'll give muscle relaxers if the patient is really having a problem. Sometimes we'll avoid that if they are going to cause some kind of sedation, which they could do too.
Heparin.
Yes, that's the one I was looking for. Somebody
and TPAs.
Patients. All right, so we're going to give heparin and we're going to give Coumadin. Why do we give heparin and Coumadin together? I want you guys to think about
Elisa
that.
says, why do we give statins at night?
Oh, that's a good question. Your cholesterol is normally synthesized at nighttime, and that's when it normally increases and is released by the liver, which is why you're going to match up your statin at nighttime to decrease that cholesterol. Okay? Anybody know why heparin and Coumadin are given together? And then tell me what TPA is. Okay?
They said we'll send the patient home on Coumadin. It takes a while for Coumadin to work.
All right, so it does take a while for Coumadin to work. Coumadin is typically given PO. Heparin is typically given IV, though it can be given sub-Q. But for this patient, we're going to give it IV. Remember that heparin and Coumadin do not treat active clots. They are preventing future clots, all right? If the patient is already clotted from all this atherosclerosis and junk and platelets that have built up in their vessels and their coronary arteries, they're definitely at risk for clots later, okay? And so on this patient, we're going to start them on heparin and Coumadin. Heparin will work immediately while we wait for the Coumadin labs to be fixed. Come over here with me really quick. We're going to talk quickly about
Chloe says TPA is a clot buster.
Yes, so TPA is the clot buster. Heparin and Coumadin are going to prevent future clots, all right?
And they're going to need PT and PTT. INR.
Yes, they sure are. So let's talk about what this looks like really quickly. I'm going to do a quick heparin and Coumadin charts. Okay, so we have heparin. We have Coumadin. We know that Coumadin is given PO, right? And that heparin is given usually IV for this patient, okay? Labs that we want to draw for heparin are, I think somebody said it already, right, is our APTT. For Coumadin, it's going to be a PT and an INR, okay? So we're going to watch our APTT levels, we're going to watch our PT and INR, which I'm sure that we drew on our labs already, right? Okay, I didn't see it. And then we're going to watch for normal versus therapeutic levels, okay? So watch that always on your nursing exams. They may tell you a normal level, and then they'll tell you a therapeutic level. The best way to remember the Coumadin with the PT, or the best way to remember the PT level is PT is a preteen, all right? So preteens are usually age 11 to 13, so that's a normal level. INR is almost always 1, which if everything in nursing school was 1, wouldn't it be so much easier? Okay.
Amen.
The normal APTT level, they're going to see 1,000 different levels for this. So about normal is going to be somewhere around 15. All right. Your therapeutic level means what do I want my patient on because they're on one of these drugs. So this is telling me the 15 and the 11 to 13 is telling me about how long it takes my patient to clot in seconds. So a normal healthy patient with normal levels, it would take about 15 seconds for them to clot. I don't want it to take that period of time for my patient. I need to thin out their blood. So the therapeutic level is going to be sometime 2 to 3 times the normal value. So you're going to multiply this times 2 to 3 times, and that's going to give you somewhere between 30 to about 45. That's my therapeutic level, all right? With your PT, you want it to be about 2 times or so. So we want it to be somewhere between 22 to 26. That is a therapeutic level. Your INR, you want at least 2 to 3 times the normal, okay? So if it's 2 to 3 times the normal, you want it to be somewhere between 2 to 3 therapeutic value. You're gonna see these levels are a little bit different everywhere, no matter what school you go to, so you need just to kind of get the norms, okay? All right, so we know normal versus therapeutic levels, so we're trying to get into the therapeutic levels. If we get higher than the therapeutic levels, we need to give an antidote. What is the antidote for heparin, and what's the antidote for Coumadin? Don't look.
Coumadin, vitamin K.
You got it. So, Coumadin is vitamin K. Do not get this confused with potassium just because you see K. People do that all the time. Don't make that mistake. The antidote for heparin is, did anybody say? Protamine sulfate. All right, so you need to have those on hand in case we get levels that are higher than therapeutic
Diana
range.
just said it. It
Nice
just
work.
came in.
Good work. So we're going to come back over here and finish our plan of care, okay? All right. So on this patient, yeah, we didn't draw our bleeding labs, so that's trouble. So we're going to go back and fix that and tell the patient, I am so sorry, I forgot to draw these labs. I'm going to have to stick you again. So we're going to do a PT, we're going to do an INR, and we're going to do an APTT. All right? And apologize to Mr. Jones for our error, okay? So we've given these medicines, we've done these diagnostic tests, we've done these labs. Now we're like, let's get this patient into cardiac cath really quickly. So I know that you guys have had a lot of things that you've been kind of putting through. Casey, do you remember any of the stuff that they put through for pre or post?
Yeah, they said consent, number one.
Definitely. So we need an informed consent.
Jamie says, why can't you just draw it from the IV?
You can't draw it from the IV, but think of it this way. This is why they usually don't, is because if your IV is infusing any electrolyte, so you're saying normal saline, or you're doing normal saline with some potassium in it, right? We sometimes will add 20 milliequivalents of K, depending on what your patient's doing. It takes a lot of blood that you have to take out in order to not get any of that in your sample, so it really is not best practice to draw blood out of an IV. It is much better practice to do a straight venipuncture because I'm not getting any mixed electrolytes in, okay? So we have an informed consent. So we're about to go into cardiac cath, and we know what cardiac cath is. You're about to take something that goes into the groin, and it's going to go, a camera that goes inside, right, all the way up inside into the heart. You're about to go in through the femoral artery. Like, this is a big deal. The femoral artery, obviously, lots of blood flow, right? And so if there's a whole lot of blood flow, we need to be cautious about a lot of different things. So knowing kind of what we're doing, we're going in an invasive procedure into an artery, going into the heart to look, give you some things we'd be worried about, and that will give you your pre-care for cardiac cath.
Vital signs.
We definitely want to do vital signs, and people I know we like to say, let's do a set of vitals. Well, the patient, we need to know if they're bleeding. What would the vitals look like in a patient that was having an acute bleed because we nicked the femoral artery, okay? We would know quickly, so we need to know what it's not even their normal, because right now they're having a heart attack, right? But what their vital signs have been over the last couple hours, so that I know if there's a drastic change. And we would see a drastic decrease in their blood pressure because we're bleeding out, less volume, less pressure. And your heart's going to compensate by getting tachycardic. So you would see hypotension and tachycardia whenever we're having an active bleed, okay? So you need informed consent, you need to check vitals to kind of see what their baseline has been like. What else are we going to do?
Bleeding precautions.
All right, we're going to do bleeding precautions. What's included in bleeding precautions? We don't want this patient to bleed, right? They're on heparin and Coumadin.
Yeah.
We're going to keep them on heparin until the PT and INR are within more normal range. And then we're going to take them off of the heparin and just leave them on the Coumadin most of the time for up to 6 months, okay? So with this patient, we need to do informed consent, vital signs, bleeding precautions. The bleeding precautions are going to include straight razors, or not straight razors, right? Electric razors only, no straight razors, because we don't want the patient to cut themselves. No rectal temperatures, right? And there's 2 reasons why we wouldn't want rectal temperatures for an MI patient, right? First of all, we don't want to go there, okay? But the rectal temp we don't want to do because that can cause a little bleeding around the anus. And even just a rectal temperature can do that, and we don't want this patient to bleed. The second reason is we don't want any vasovagal response from this patient. So when you have a patient that comes into the ER and you think that they're having an MI, then we always tell them, do not poop, right? And we're not trying to be mean, and we just say, like, dude, if you poop, you're going to vasovagal, and a vasovagal response is going to cause your heart rate to drastically decrease. Well, if I already have significant bradycardia because my patient is having a giant heart attack, these are the people that die on the toilet because they have a vasovagal response from pushing.
Elvis Presley.
Yes. And then their heart is just going to stop because they get this vasovagal response that causes bradycardia. They are already low. Patient's heart stops beating, okay? So it's really important that we don't activate that vasovagal response. We are also going to check all of their body fluids for bleeding, right? So check urine and vomit and all of those places for bleeding, all right? Try not to do venipunctures if you have to, but that's after they've been on it for a little period of time, okay?
We have check for allergies, NPO,
checking for allergies
skin prep.
is one of the most important things we can do. So we're checking for allergies to shellfish and iodine, okay? And the reason we do that is because the contrast that we're about to put in, if you're allergic to that, you're also allergic to the contrast. Last thing you need for us to do is to cause you to go into huge anaphylaxis because we didn't check for allergies. So that one is usually priority to make sure that we check that first. And you guys already checked that up at the top, so I'm really proud of you for getting that one. Now, somebody said something earlier about metformin, okay? So
yeah, they
if they are on metformin, we do want to hold the metformin because metformin and contrast compete against each other for kidney excretion. And I don't want one of those to lose. If the metformin loses, your blood sugar is going to go low, right? And if your contrast loses, then you're going to have a buildup of contrast, which can be toxic to your body. So you want to make sure if they're on metformin, they hold that dose if we're able to, all right? Because that contrast does have to be excreted by the kidneys, which is why when you drew your BUN and creatinine earlier, I was really proud of you because we have to draw those kidney functions to make sure that their kidneys are healthy enough to be able to excrete the contrast, okay? So we've done an informed consent, vital signs, bleeding precautions, check for allergies. There's another big one that you guys are missing because we're about to go into an artery, right? And an artery's job is to carry blood flow away from the heart. So if I nick something or I hurt something or I messed up something in some kind of way, I'm not going to get perfusion to the rest of my leg, right? And we would see one of the 5 Ps. So one of the big things that you need to do pre-cardiac cath is to check for pulses, okay? and you're going to mark them. Actually, with a Sharpie marker, you're going to mark the pulses so that and you're going to write down the strength. That way the nurse that gets the patient in post-op is going to be able to know what the strength was. A lot of times patients with an MI already have peripheral artery disease, and so their pulses may be a little bit diminished, and so you need to mark that. Because if I'm a nurse that's post-op and all of a sudden I say, this patient's pulses are diminished, I'm going to freak out and think that there's something wrong. So you need to check the pulses and mark them and write down their strength. Okay? All right? Now, what do we do post-op? This patient, we have gone into the femoral artery, we've looked around, we've messed around in places, and we've come back out. So your biggest risk immediately would be bleeding. Your biggest risk longer term would be infection. But right now I have to watch for the bleeding. So how are you going to position this patient and for how long?
Jamie says pressure on site.
Yes. So we are going to lay
Keep that leg flat.
Nice work. Who said that?
Amber Holland.
Good job. Oh, I know her. What's up, Amber Holland?
Oh,
all
girl.
Right. So
for 6 hours,
flat.
4 to 6.
Yes, with the leg straight for 4 to 6 hours. All right? And that's because we don't want to move it. We want it to clot right there so that we don't have an active bleed. So you're going to have them lay flat, leg straight. Some places and some hospitals, you can put a sandbag on top of it just to keep some pressure. All right? Watch your 5 Ps. All right? So you need to be watching the pulses. All right? So you're going to be checking pulses Q15, all right, to make sure that there's no difference, because I want to make sure I don't lose a leg on my patients, okay? My patient came in with 2 legs and wants to leave with 2 legs, and I'm going to make sure that that happens, okay? So I'm going to check for the 5 Ps. I'm probably going to get 1. I always miss 1. All right, paralysis, pulselessness, pain, pallor, paresthesias.
Nailed it.
Some places out of 6, which is like picholothermia, which is weird. I don't know.
I can't even spell that.
Exactly. But those are your biggest 5 Ps. And if you notice that any of those are off, right? So you check the pulse, and the nurse before you said that it was 2+, it was strong, and now it's 1 and weak. Call the physician immediately. One of the only times in nursing will ever tell you call the physician immediately. There's nothing else you can do for that patient. Putting warmth on it won't help. All right? Nothing we can do will help elevating it. For the love of God, don't do that. Okay? So that won't help. There's nothing we can do. This patient has to get into surgery in order to clear the problem. Whether they have nicked the artery, whether there's a blockage in there, something is going on to where we're not getting perfusion to the bottom. Okay? So watch for those 5 Ps. What happens if you go check on your patient and you pull the sheet back and they're laying in a puddle of blood? What's the first thing that you're going to do?
Don't scream.
Don't scream. It's also a very good choice, because as a nursing student, I'd be like, "Wah!" You know? Anybody?
Oh, he said fluid for kidneys and watch kidney function post-op.
Oh, yes. Okay,
From
so post-op,
contrast.
yes, we can watch kidney function. So we'll watch our BUN, creatinine, and give fluids, definitely. All right. So on this patient, did anybody see? Oh, God.
There's pressure 2 inches above the site.
Good. So we're going to put pressure 1 to 2 inches above the insertion site, not on it. Okay? Because if you put it on it, it's still going to be pulsing out around it. So put pressure above it. Do not put on a tourniquet. They will always put this on nursing exams. And once you actually think about it, you're like, that was probably the dumbest answer I've ever picked. Because if your femoral artery is here and you're applying a tourniquet, you'd have to basically wrap it around their waist. That's not a good idea.
Never a good idea.
Yes, please don't cut your patient in half. I mean, these are just basic nursing things you'll learn from
The tourniquet belt.
The tourniquet belt. It's new and it's coming out. It's replacing fanny packs. Okay, don't.
That
do
is trademarked by Ivy League Tutoring.
That's right. Don't steal it. Okay. So so we definitely want to put pressure above the insertion site. Call for help. The physician's going to have to come out there. The patient's probably going to have to go into surgery. All right. All right. Your patient has survived so far. Okay. The only thing that we did not really discuss, what you guys said, was to give the TPA. TPA is a clot buster. Remember, whereas heparin and Coumadin are going to prevent future clots. All right, I just wanted to point that out. Let's talk really quickly about, are we out of time? How are we doing on time?
110.
110, we're out of time. Okay, so what I want you guys to do is to post in the comments what you would do for the patient, teaching for this patient. We have gone through the entire plan of care for this patient, from his risk factors and what he did for this atherosclerosis and how this happened, to angina that's stable and unstable, and then that led to the unstable angina, it led to this big giant MI, And then we did all of these things for our patient, took care of him, got him into cardiac cath lab, we treated him. So now we need to get him ready to go home. All right, so I want you guys to leave some patient teaching in the comments. I also want to hear from you now. We're going to keep the live feed for a few minutes. I want to hear from you and let me know what you wanted me to do for next week. All right, we're going to do a new plan of care for somebody else, for anything you guys want me to cover. We did Cushing's and Addison's last week. We did MI this week. Let me know what you want to hear about. Make sure that you're following us on Facebook, Instagram, Twitter, and that you subscribe to our YouTube channel because we will be posting this video there later, okay? If you guys have any questions, you can feel free to email us at there's no Y, ivleaguetutoring@gmail.com, or you can message us on the Facebook page, all right? And do make sure that you sign up for our text alerts, 85100. You're going to text nursing to 85100. We will see you guys next week. We'll probably be popping in for a couple videos here and there, all right? So I'm glad you guys joined us today. Y'all did really well. Your patient survived, and he lived, and Mr. Jones gets to go home and watch Jeopardy again. All right, so we'll keep the, you guys can keep commenting, and the video will be posted shortly, so make sure that you go over onto the YouTube channel and grab that. We'll try to post on the Facebook page again today too, all right? So thanks for joining us today. You guys did awesome. You were really, really good, and we will see you next week.
Perfect. Bye guys. Thanks, Cassidy, showing up with the Go Dolphins.
Good.
What do y'all want to see next week?
Nothing yet. It's probably coming. Oh, one more thing before we go. We'll also post pictures of this up on the Facebook page too, so you'll have the pictures that I drew today so you can get a close-up. You guys should be able to follow those pretty well. All right, so we'll see you guys next week.